So these are 4 of my brain tumor patients that I've taken care of over the course of the last 10 years. All of these individuals are in their 40s. All of them are parents. All of them are in the prime of their life, having careers, embarking on all kinds of different aspects and avenues within life. And they all presented with something a little bit different: headaches, seizures, a little bit of confusion, memory. And they all had these sort of distinct radiologic findings. So this is an axial or sort of a cross-sectional view of the brain. And the circles are the areas where we think the tumor is. And it probably is relatively straightforward to see that some of these are very discrete lesions that may be able to come out. You sort of can draw a circle around them and be able to remove them. And some of these are much more hazy and diffuse. And you can imagine trying to take a lot of this out probably takes out a lot of healthy brain as well. And I think that these are a range of different MRI features as we meet with patients early on in their journey. So this is kind of how things started off at the beginning. So all of these patients went on to receive surgery, and all of these patients were found to have an IDH mutation in their glioma, all different corners of the brain, if you will. As it comes across how excited we are about this new place, I think in the context of where it is that we've been and the ambiguity and gray zone that we've been living in is really an important thing, I think, for patients to also kind of understand and grapple with. And so the WHO is the World Health Organization. It's sort of how we brand gliomas, if you will. And for many, many, many years, we mostly were using the 2007 WHO classification. And what this really did was we took the tumor sample out. You would look at it under the microscope. You would sort of see if it kind of looked a little bit like an oligodendroglioma or a little bit more like an astrocytoma. It's somewhat ambiguous, as you can see. And the grade of grade 2 and 3 and then 4 was also somewhat subjective. And so depending on the size of the sample and where it is that the tumor was taken out, and therefore the pathologist who was examining it, there was a lot of variability in how these tumors were defined. So this really created and set up a lot of variability in how it is that people were treated with these grade 2 versus 3 tumors. And glioblastoma does not harbor the IDH mutation, and we're not going to talk about it very much today. But again, just sort of a focus of, as we increase in number, that the aggressiveness of the tumor also increases. And then in 2009, it was discovered this IDH mutation. This is where this mutation comes from. And so isocitrate dehydrogenase is what IDH stands for. And what it normally does is produces alpha-ketoglutarate, which is here in this particular slide. Normally, isocitrate gets converted to alpha-ketoglutarate by IDH1 or IDH2. However, if you have this mutation, an IDH1 or an IDH2 mutation, instead of generating this alpha-ketoglutarate, you end up generating 2-hydroxyglutarate. And what we've learned since 2009 that this is something that creates tumors. It's oncogenic. It creates disruption of the DNA and the environment of the tumor. It makes it more hypoxic, and it is a driving function for patients who have this IDH mutation. And we don't know what causes the mutation. We don't know how long it takes for these tumors to develop. We think probably a couple years, but the logistics of that are not really well known. But this is a functional, really critical mutation. And what we saw is their patients in grade 2 and 3, sort of these lower grade, slower growing tumors, that 80% of them seemed to have this IDH mutation. And people with glioblastomas or grade 4 tumors, only about 5% of them seemed to have this IDH mutation. So it was also something that you could see really easily under the microscope, and it was kind of black and white. The brown stain here, the tumor cells. So you take the slide and you sort of put this antibody to stain for the IDH mutation. So if the brown cells come back as positive, and you can see then these are blood vessels, so they're blue, which means they're not positive for the mutation, then you know that you have an IDH positive tumor cell. And regardless of how small your sample of your tumor, you can potentially identify this. And so this was a very novel, important way of identifying these tumors early on in the diagnosis, even right after the microscope. So a lot of times now, within a week, we sort of know the answer of whether or not the IDH mutation is there. This is called a Kaplan-Meier curve. And on the y-axis here are percentages, and the x-axis is time. So at the beginning of this journey, 100% of people at time of their tumor diagnosis are alive. As you go over time, you see that these curves decrease, some of them very steeply, some of them a little bit more in a stutter step over time. And these are based on the 2007, so the way we used to classify these tumors. My point in showing you this is that it's all sort of a mess. Like there's the orange group that's down here, the glioblastoma, but the 2s and the 3s and the oligodendrogliomas and the astrocytomas, it's all just sort of mixed together. And this really reflects how we've been treating patients. Some people with grade 2 tumors don't necessarily do as well. Some people with grade 3 tumors seem to live for decades. So it really mirrored the clinical experience. However, when you add in IDH mutation, you start to see a little bit more separation. You have the blue and the purple here, which are people who have the IDH mutation. And those people's, their curve is a slower curve. So people are living longer, many people even decades. And then you have sort of this in between where mostly is astrocytomas, but you still have this IDH mutation. By knowing whether or not a patient has an IDH mutation, it really helped us sort of clarify the patient journey. And so this really updated in 2016 how it is that we classified tumors. So the WHO, the World Health Organization, said, okay, in order for you to define a tumor, a brain tumor, you have to know its IDH mutation status. And then in 2021, so just a few years ago, they really did a big overhaul and revamp and said, okay, now you absolutely have to know the IDH status. These astrocytomas, if they have the IDH mutation, they can be grade 2, 3, or 4. And oligodendroglioma is either graded grade 2 or grade 3. And essentially, a glioblastoma cannot have an IDH mutation anymore. And so that really helps us understand as we think about therapeutic targets for patients who have glioblastomas versus patients who have an IDH mutation, that we're really thinking about these illnesses differently. Whatever caused this tumor, how it might respond to different treatments. While there may be some overlap, they're also very different, and we probably need to be thinking about them differently.